So tonight's topic is speech therapy, physical therapy, and LSVT. If you read our newsletter or attend our roundtable meetings, then you know we've been discussing speech and swallowing issues pretty regularly for the last few weeks. We posted an article in our last newsletter about at-home swallowing exercises, and we've discussed how physical therapy can help everything from voice volume to appetite. For example, if swallowing is difficult, we do tend to eat less. We've also talked about the effects of not pursuing solutions for your facial and throat muscles. These can be minor, like drooling, or they can become fatal, like aspiration and getting bits of food in the lungs and getting infections. So I'm not fear-mongering, but there is a really strong progression of events if you don't address voice, speech, or swallowing issues. We also constantly talk about the importance of exercise to preserve movement and slow the progression of Parkinson's, improve your balance, prevent falls. Exercise is one of those early and regular stopgaps you can do to improve your quality of life with Parkinson's. So given these conversations, it did seem obvious that it's time to bring out an expert to answer all your questions firsthand. So I am excited to introduce tonight's incredible speakers who will be discussing LSVT BIG and LOUD. You might recognize Brandon from his twice monthly movement use it or lose it classes. And Jayme joins him tonight. Jayme McLeish. She's got a lot of letters after her name. I'm going to read them all out. MS, CCC-SLP, ATS, and OMFT. I know that Jayme will be addressing what all of those mean during her presentation. And Brandon, don't want to forget about you. Brandon Rosi is a DPT, CSCS, and certified DN, certified MSKUS, and I will leave it to you, Brandon, to explain what all those letters mean. So we're going to jump into it tonight. We're going to hear from each of them, save your questions, and we will ask them at the end of each presentation. And we're going to jump in with Jayme, who is our speech therapy expert tonight. So Jayme, take it away.
Okay, I will. Let me share my screen. And I'll start off with a brief introduction about who I am and where I work. So I am a speech language pathologist. I work a few places in the desert. So with Rosi Physiotherapy, Desert Oasis, and also Riverside County Office of Education. And I am a member of ASHA. We have to be a speech pathologist. And then a little bit about me. I've been in the field for 17 years. And my areas of expertise are treatment for patients who are deaf and hard of hearing, use assistive technology. So that would be people that need to use some kind of alternative communication, like a communication board or a device to communicate. Or for some people that might need to be louder but aren't able to do that themselves anymore, you might need to use a voice amplifier. I specialize in that. So that's actually the ATS is assistive technology specialist after my name. And then also oral myofunctional therapy. And what that is the movement of your face and what we call your articulators. So your tongue, your lips, your cheek, and then using the muscles that you use for speaking and swallowing. So it's evaluating those to make sure that you're using them properly and functionally, so that we can not only understand you, but so you have appropriate facial expressions, things move correctly, and then you're able to safely swallow. And then I have been treating from birth. I think my youngest patient was a few weeks old, and my oldest patient has been 104. So across the lifespan, and that's been really exciting. And then I have done a bunch of different kinds of presentations, Assistive Technology Institute conference, and I've treated and consulted nationwide and a little bit of consult internationally too. And then this is just what a speech language pathologist does. I think a lot of the times people think we just work on speech or swallowing, but we also work on things like language. So understanding what people are saying and having all of the words that you need to express yourself, being able to do more complex language tasks. Sometimes that can get more difficult with Parkinson's. So being able to put together tasks like calling someone, making plans to do that, social communication, talking to friends, staying involved in conversations, voice and fluency. So volume, that is one of the things that is definitely focused on with Parkinson's. And then fluency is the ability to understand you when you speak, how fluently you speak, feeding and swallowing, and then cognition as well. So activities that are cognitive can be anything from your daily activities, so being able to plan how to make coffee, to hobbies. They can also be things like if you needed to calendar different activities, those are something that we help with too cognitively. And this is how speech therapy can help with Parkinson's. Parkinson's can affect various aspects of speech and communication because of the muscles that you use for speech and swallowing and facial expressions. I don't know if you've focused a lot on something called hypomimia. Have you focused on that before, like more mask-like facial expressions? So that's something that we can work on too. Okay, speech intelligibility. Parkinson's disease can lead to reduced volume, monotone speech, and difficulty articulating words clearly. Speech therapy can focus on exercises to strengthen the muscles involved in speech production, improve breath support, and enhance articulation for clearer and more intelligible speech. Something that gets focused on frequently when we're working with Parkinson's is volume, so speaking louder, and then speaking with intention. And those are two of the bases for two different programs, for the LOUD program and then also for the Speak Out program. So what happens with your voice when you're speaking and you need to speak intelligibly is we are very used to just not really stopping to think a lot when we talk. We just usually speak and the words come out. When you have Parkinson's, you have to really focus on what you're saying and how you're saying it so that you're able to speak more clearly. And then voice. So Parkinson's can cause changes in voice quality like hoarseness, breathiness, or strained voice. Speech therapy techniques can help you to develop a stronger, more resonant voice by addressing vocal cord control, breath support, and vocal projection. This can be done with exercises and also with muscle training. We have some devices that we sometimes use to help with this as well. And then swallowing. Swallowing is really important. I think it's one of those things that people will sometimes put on the back burner and say, oh, I just cough a little bit. So as soon as you notice that you have any changes in swallowing, and sometimes the first change in swallowing is you might modify your diet. You might not even notice that you're swallowing or chewing really differently, but you might just think, I want to eat softer foods. Those are usually early signs that you're having difficulty swallowing. So if you start to notice those things, that you might want to consider seeing a speech therapist for that. And then facial expression. So speech therapy can include oral myofunctional exercises to improve facial muscle strength, mobility, and control. We sometimes will incorporate those with voice exercises. Sometimes we'll also just work on isolating those facial muscles as well. And then cognitive communication skills. So providing cognitive communication therapy to address challenges like executive function and memory, attention, and then improving communication strategies, comprehension, and problem-solving skills. And then alternative communication methods. If you are having difficulty with doing exercises, it's usually more towards the end of your journey, then we will look at alternative communication and how we can help you communicate with your loved ones using amplification or a board, things like that. Okay. And the impact of speech therapy on overall quality of life. So regular sessions can help individuals manage communication challenges and connect with others effectively. And tailoring them to what you need, your your goals is really important. So knowing what you want to work towards, so you want to communicate more with your family, we want to help you with that. If you want to be able to plan events and get out and go do them, you want to talk to others, you want to be able to swallow and go out to eat, and you are worried about you're going to choke in a restaurant, we want to work on those things. A speech therapist is actually a speech pathologist. So they're the same person. Sometimes they will have what they call a speech pathology assistant. Sometimes they will have clinical fellows. So they're speech pathologists. They're just newer to the field, and they're still in the process of being certified. So that may be what happened. They might be supervised still.
So Jayme, I'm going to interject and put you back on the hot mic, but talk to them about the Speak Out program versus the Loud, because I guarantee that question's someone's brewing it anyway.
So the LOUD program focuses a lot on volume. There is a lot of auditory feedback, and so what we would tell you very consistently is to use your loud voice. That is something that you will hear with the LOUD program. A lot of the actual exercises are very similar to the Speak Out program. The Speak Out program is focused on the intent to communicate. The brain has two systems that you use when you're communicating. So actually, I'll have you do an activity. If you count to 10, just 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Can you do that for me? Can you count to 10?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
So I saw some people go really fast, and some people, you kind of bobbing along. You're used to doing that. It's what we call an automatic speech task. You can do that without really thinking. Now I want you to count backwards from 20 to 1.
20, 19, 18, 17, 16, 15, 14, 13, 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Perfect. So even just with Eileen as an example, her voice got louder, her speech was clearer, she was more deliberate, her lips moved more. I watched everybody on screen. So that's the difference between intentional speech and automatic speech. So what happens is with Parkinson's, your automatic speech system, it's not as good anymore. So we need to use a different method in order for you to speak more clearly. And it's with more intentional communication. And that's the focus of the Speak Out program, is making your communication intentional. It will be somewhat louder, but it will feel more natural because you don't feel like you're shouting at people, but both are good models. You end up with similar results at the end. It's just two different approaches. Does that make sense?
That was a really, really fascinating example, Jayme. I think you did a really great job describing that. Loud emphasizes volume and Speak Out emphasizes intent to communicate. And kind of both are important, but really well said. And what an interesting example you just had us run through.
Not necessarily. And Brandon can speak to this more. He's on more of the administration end of that. That can also be prescribed by the general practitioner as well.
For anything with regard to for Jayme, anything in regard to speech, it does require a referral from any of your providers. It could be a nurse practitioner, one of their physician assistants, your primary doctor, your neurologist, your movement specialist. I know Dr. Legg and Dr. Song are kind of like the common ones I work with a lot with the PRO group, but it could be any of your providers. It most typically is the neurologist or your primary care, but that is not a requirement by any means.
It can, and one of the things that we do is virtual therapy, so we can actually see anybody in California.
I do think that it is more and more possible to get virtual appointments, and especially for something like speech therapy, it's a little more accessible than if you're trying to do a virtual physical therapy appointment. Yes. So I wouldn't be surprised at all if you could find some great providers in Connecticut.
I don't know.
Jayme, I wonder if you have any information on the connection between speech or loss of speech and loss of memory or cognitive function. Is there a connection there?
Yeah, so communication and cognition are very closely related. So we often look at people's levels of communication to determine what their cognition is like. So as people do lose speech, then they can lose cognitive, especially higher level functioning activities. So things like remembering dates, remembering you wanted to call people, what we call executive function, so knowing how to plan things, being able to do a job, those kinds of things can become more difficult. Yes, there are. So oromyofunctional therapy, we look at how your lips move, and some of the exercises that you can do on your own for helping with your lip movement are what we call pursing and retraction. So pretend you're kissing someone like a grandma. Good. And then you're going to retract. So the biggest smile you can give me. Good. And then you want to go into an O. And then my niece calls this scary cat. I don't know why she's going to basically retract your cheeks. Think about opening your mouth and smiling at the same time. And then practice doing that on a loop. So you're going to purse your lips, smile, O.
That was great, Jayme. Thank you for walking us through those.
Oh, my pleasure. They give you all an exercise that you can work on for hoarseness right out of the gate. So get a cup of water and get a small glass with about an inch of water in it and a straw, and start blowing into the water. So what happens is your vocal folds, they need to close completely in order to create subglottal pressure. And then you also have to have them close completely when you swallow. Our vocal folds are very, very important. One of the problems with Parkinson's at early stages is that aging voice and Parkinson's can look very similar. So they may be thinking, oh, you're fine. You're elderly. Your voice sounds like you're aging a little bit. But to you, you're like, this doesn't feel right. This isn't what I thought was supposed to be happening.
Right.
So so now you know you have a Parkinson's diagnosis. So there are things we can do. So what I would do is start blowing in about an inch of water. And I do it to what we call to fatigue. So that's until you run out of breath. Do it about 3 times in a row, 3 times a day. So we're working on opening and closing those vocal folds and giving them a little bit more exercise. Okay. So that's one of the things I would start with doing. The other things that you can start working on is fairly easy. And it is what we call glottal attack. So, ha, ha, ha. And that's basically just where you're making intentional sound. Again, it's intentional communication. And you're creating a sound that's bringing your vocal folds together, but you're not coughing and you're not banging them together. So that's helping them move. I would do those 2 things, and I'd start with doing 5 to 10 of those repetitions of ha a day. And think about the other thing that happens with Parkinson's is when you don't have muscles that are functioning appropriately, other body parts want to take over. So we tend to not use our systems as completely as we might. So having biofeedback, which is where relying on your body in a different way to give you information about what you're doing, is better. So when you say ha, okay, if I do it like this, ha, ha, do you see my shoulders move a lot and I'm not very loud? If I go ha, ha, I'm using my abdomen and those muscles are moving and then my vocal folds are moving. So you want to have more air pressure, you're going to create it in your stomach. So everybody put your hands on your abdomen. I want you to take your hands and put them on either your lap or on the table, whatever you're sitting in front of, okay? And then hold them there and say, ha, okay? Everybody sounds a lot softer, and your cords sound tight, right? Can you hear that? Yeah. So you want your abdomen to move. You need the biofeedback. So I'd start doing those 2 things.
Well, let's switch gears and talk a little bit about exercise then, and Brandon's forte. Some of you do know Brandon from our Movement Use It or Lose It class, which is guided exercises that you can do at home. But Brandon today is going to be talking more generally about the importance of exercise and LSVT programs like that. So Brandon, take it away, and then we will open it up back again for questions.
All right. All right. Hi, everybody. So in the beginning, I think it was Eileen, not Wendy, who had mentioned that kind of occupational therapy and speech therapy, physical therapy and occupational therapists, two separate medical professionals, are both able, if certified, to provide the LSVT BIG program. The BIG program meaning big movement, big activity using your body, versus the LSVT LOUD is always through a speech therapist. So I'm going to be speaking about the LSVT BIG program, or of course, any questions you guys may have in general, but I am one of many of the big providers, as we kind of shorthand and call it. But I do provide the LSVT BIG program. Now, with regards to that program, I think most people have at least heard of it. So I'll kind of breeze through it a little bit quicker. And if you have questions, feel free to ask. But the program itself is a total of 17 sessions. The first session, of course, is just your evaluation to determine if you are a good candidate for the program. The following 16 sessions, if you are a good candidate for the program, you would benefit from it. Then you would set up, and it's 4 visits in a week. So think Monday, Tuesday, Wednesday, Thursday. So I'm sorry, it's 4 consecutive visits direct with the provider in a week for 4 consecutive weeks. So many a times, and I did see that question, many a times I would see patients Monday, Tuesday, Wednesday, Thursday for 4 weeks in a row, and that is the entirety of the program. The LSVT is the LSVT, it stands for Lee Silverman Voice Treatment, which is Lee Silverman. It's the first patient that the speech therapist provided it on, and so it was kind of named after the provider, the speech provider, and then the patient, and so it became the LSVT program. Once they determined and they had such good success with the LSVT program, actually physical therapists kind of copied off of the speech therapy world, and we said, hey, this intensive program helped get patients louder and better with their quality of their voice. Why don't we kind of mimic it with an effect for movement? And then because of kind of confusion, that's when they renamed it the LSVT LOUD. It was originally just LSVT, and that was the LSVT LOUD for the speech component, and then the LSVT BIG for the kind of physical body component. So that's just the LSVT program itself. I think a question I get a lot, though, is just with regards to the program. Not everybody qualifies for the program. It's not like you just go through the mix. Many patients do. I say this as a many patients come to me that are early diagnosed, and as soon as they get diagnosed, a lot of times they'll go and they'll read about it, and the first thing it'll say is you got to do the LSVT LOUD and the LSVT BIG. Many a times those patients come in, I evaluate them, and I actually say something along the lines of, you are too good. You don't need this program yet. We'll touch base in 5 years, 7 years, call us in a year. We'll do another quick assessment, and we'll see, at what point do you qualify, or what point is it beneficial? Now, if you don't qualify, that's a good thing. That means you're doing even better or more well than you think, in which case that doesn't mean we just throw you to the wolves. We do other things. For individuals that have gone through the program, which is this probably the question I get the most, is if you've done it once, can you do it again? The answer is absolutely. Do you need to do it again? Probably at some point. Do you need to do the same 4 weeks, 4 times a week for 4 weeks program? Not necessarily. I think I've done at least 50 different patients on the big program in the last 5 or so years. I've had a handful of patients that have done a full circuit of the entire program a second time. Many other patients, and I would say more commonly than not, is we will do some sort of like tune-up session, I call them. I'll say like, let's tune in and tune up, meaning you tune in for like, 2 more weeks, and we'll see you twice a week for 2 weeks. So think of like a really short abridged program just to kind of jumpstart the system, kind of get the cobwebs out, and then kind of refresh on that. And then we kind of, can switch gears into other kind of forms. Does that answer, or does that help? As far as the program itself, I'm sorry, I don't think I spoke about this. The program itself focuses first and largely on, can you get in and out of a chair? Can you get in and out of bed? Can you walk throughout the home? Can you get in and out of your car? And really, all of it is designed to get you out of the house. Because one of the things I see with my patients with Parkinson's is they very quickly become a turtle. And so I always call it the hermit crab disease. We slowly kind of itch away things out of our life that we either enjoyed or did but can't do anymore, either because of fear, because of a new challenge has arisen. Similar to what Jayme was saying earlier, you may start eating less harder foods or foods that are more chewy. You may eat those less and less. You may start to take things out of your life or out of your diet because they're challenging, and may not even realize you're doing that. The same thing happens with the body. Sometimes one of the most common things I hear with patients is, I can't use that chair anymore because it's too hard to get out of. It's my favorite chair, but I can't use it. That chair's in my den or it's in my office. And so I'm just not in the office anymore. Or another thing I got was a couple of years ago, I had a patient who, him and his wife's favorite thing to do together on date night was to go to the movie theater. But it was challenging for him to get in and out of the movie theater seats. And traditionally he would not worry, but he usually had to go to the bathroom at some point during the movie. And so it's not so much as when the movie's over, but when the movie is in the middle of the movie, he did not like struggling and then getting in kind of interrupting the experience for the other patrons. And that was a big affect to him that kind of belittled his activity that he enjoyed doing. So that's part of what we work on with that program. It starts with like what's called these 10 maximal daily exercises, which everybody does every single day for all 16 visits. And then you also have homework. And then the rest of the program is geared towards what you each individually, and me or whatever your provider is, we come up with to determine what it is you want to work on. And that's the real fun stuff, because that's incredibly designed for what it is you want to do. And every single patient is different. So I could give tons of examples, but it's truly just whatever it is you like to work on. Each session runs about 45 minutes to an hour.
Okay.
Usually I like to have them at an hour. In the event, the goal, the prescription is standardized around 1 hour. There are patients that usually have difficulty tolerating the full hour, especially in the beginning. Many a times the first week, the 45 minutes is a lot. By week 2, patients really start to bust out the cobwebs. And then by week 3, that's where the ball really gets rolling. But the program, when we do it here, we set it for an hour. There's a lot you can do. The biggest problem and kind of the question is there any pain? Is there any limitation when doing it? For instance, most of the time, specifically with the going downhill, it's a lot of times it's more or less a weakness or a discrepancy in the knee. That not necessarily is actually a Parkinson's thing. And so actually, for those of you who have been around long enough to know me, kind of my whole claim to fame with the PRO organization 8 years ago was when my wife was exclusively treating the Parkinson's cohorts, and I, was very comfortable with it. My grandfather had Parkinson's, but my specialty above everything else, I would say, is I'm very good at macro. I'm very good at zooming out and looking at the whole patient and treating the encapsulating entirety. And what I mean by that is unfortunately, and it's sad to say, I think everybody here could probably hear me say this and say, yeah, that's happened to you. But when you get diagnosed with something like Parkinson's disease or Parkinsonisms, or you get diagnosed with multiple sclerosis, or, you know, fill in the blank with some of these really horrendous neurodegenerative diseases, you get thrown into that bucket. And society sometimes throws you into that bucket for everything. And one of the things that I saw a lot of patients with was, I've got back pain. And it's like, but I've got Parkinson's. And the neurologist said, well, you have Parkinson's. And the primary doctor said, well, you have Parkinson's. It's like, well, why did your back pain all of a sudden disappear? Because you got another card handed to you. Like that doesn't work. Why does the knee pains all of a sudden go away? They don't. And so one of the things that I really focused on was really is just this inclusive care of, okay, I see patients all day long that don't have Parkinson's, and we work with them. And I see patients all day long that do have Parkinson's or Parkinsonisms or other things. And I really like to blend the two and just take a look at what exactly is going on. And then one of the things, not to kind of shift gears, but one of the things that Eileen had mentioned at the beginning was the Cert MSKUS, which is what stands for Certified Musculoskeletal Sonographer, meaning I use sonography or ultrasound. Think, you know, looking at babies, you know, putting the probe on mom's belly and looking at babies. I do that with patients all day long, but I do it to look at tendons, nerves, muscles, ligaments, soft tissue, hard tissue. And so a lot of that is combining, looking at, you know, how are the structures in the knee? Are the structures in the knee able to perform what it is you're trying to do? Then are the muscles strong enough to tolerate what you're trying to do? Then in your case, is the brain telling the muscles quick enough what to do? And then can you make that mental plan fast enough, faster than gravity, as gravity is constant? Does that make sense?
That was a really excellent explanation, Brandon. This comes up, I think this comes up a lot in our various meetings, especially the roundtables where, you know, we're talking about a particular symptom or thing that someone's experiencing. And the question is always, is this Parkinson's or is this aging? Is this Parkinson's or is this life? And it can be really hard to discern, but it's happening regardless. And so there are, you know, one thing that we as Parkinson's Resource Organization tries to do is pull together as many experts as possible who deal with as many issues as possible so that there is a resource for each and every symptom or experience that you're having. So thank you for again reiterating that. I mean, I think that's such an important point. It doesn't matter what the, I mean, it does and it doesn't. It doesn't matter why you've got back pain. It matters that you have back pain and that there's things we can do to help it.
Yes, I don't, by the way, here's the answer. If you have Parkinson's and you have back pain, I treat the back pain. If you don't have Parkinson's and you have back pain, I treat the back pain. It doesn't change anything. It may change how fast you can do something. It may change how often you can come see me because you have other medical obligations, but it doesn't matter. At the end of the day, like our job, Jayme and my job as therapy providers, we focus much less on the diagnostics outside of, we want to know what's going on so we can find and formulate the plan, but it's much more of, we are quality of life improvement providers. That's our primary goal, is to make your life better.
Absolutely.
Well, we will be sharing that information, so don't you worry. And Jayme does virtual. Jayme, correct me if I'm wrong, actually, and Brandon, I believe this applies to you as well, but do you also travel to people's homes in the area? Or is that just you, Brandon?
That is just Brandon.
Okay.
Well, depends. For Rosi physiotherapy, I am virtual, 100%. When I work for Desert Oasis, which is home health, that's different. But that is strictly if you had some kind of event that kept you from getting around. That's when you would have home health therapy. So virtual is different. It's considered outpatient. Brandon can actually give you more information about that.
If you guys haven't figured out yet, Jayme is extremely busy. And unfortunately, the time it takes traveling from person to person takes away like 2 or 3 patients a day she can see. And um, but as you guys could kind of see a very, very small taste of what she does today, she actually can very much so do a full unencumbered therapy session, virtual. If you're comfortable and you kind of saw her doing her thing and you have a microphone, it doesn't even have to be a good quality one. Um, she is able to facilitate a lot of that. As for me, not to, switch gears, as for me, I have in the past done home visits. We do, in rare circumstances at this point, do facilitate home visits. I almost always try to get you out and into our clinic instead. And the reason is, again, time constraints. I can see more patients and I can help more patients, but also it is therapeutic and beneficial for you to get out of the house. Um, if you absolutely cannot get out of the house, then you can reach out to us. But I can assure you the conversation will very quickly be steered as to why you can't. And then if it is a matter of coming to you, then it's a matter of getting you strong enough until you can leave the house, and then you leave the house, because it is immensely therapeutic and beneficial for you to get out of the house. You guys see the same walls all day long. And we have equipment here. Well, actually, I'm at home, but we have equipment at the therapy clinic that I don't have access to.
That makes sense. So before we close out today, I'd like to ask each of you separately, what is one exercise that everyone in this meeting could incorporate into their lives easily, just one per day, that would improve their quality of life? I'll put Brandon on the hot seat first.
I was just about to say Jayme first. Okay. I would say exercise. My default exercise, and I say this to every patient, and I will absolutely repeat this, is walk. And I know that may sound like a cop out, but again, there are so many systems that we simultaneously work on by walking, including our GI health, including the mentation, including our vestibular, where our balance is, our hearing, our eyes. There's so much that is beneficial all at once. And so what I would tell every patient is, remember, getting out of the house is good. It's therapeutic. So unless you are stuck or confined to a wheelchair, my request is for everybody to get the mail every day. It gets you out of the house. It's usually a short distance. Most people, if you either have a mailbox at your house or if you're in a kind of a community complex, they usually are pretty close these days. That doesn't mean your spouse absolutely gets to go with you. You can hold hands, or she or he can walk by you. But it gets you out of the house. It gets you some vitamin D, even for a couple minutes, and you get your mail. That would be my very achievable daily task everybody can and should be doing, or strive to do.
That's excellent, Brandon. Thank you. How about you, Jayme?
Okay. I would say to sing. So if you sing every day, you're actually working all of the muscles that you use for speech and for swallowing. So that would be something that you can do easily. It's very accessible. It doesn't matter what you sing, and it doesn't matter what you sound like. So sing and drink water.
Cheers.
Hydrate.
And Jayme, what is your song of choice at the moment?
It's Beyonce's Texas Hold'em.
Nice.
The program was originally founded and designed for individuals with Parkinson's disease. They have since taken that, because now the program's been out over 20 years. They've taken that program and they've inquired and provided it to patients that have no diagnosis, not even the thought or belief that they have it. Just some people have balance or weakness, and they absolutely found similar benefits. And so you do not need to be diagnosed to perform or take advantage of this program. You do not need to have that diagnosis for Medicare to cover it. You just, in order for Medicare to cover the vast majority of the bill, you need your primary or your neurologist or your doctor of choice to provide that request, that referral.
So to encapsulate, get a referral, doesn't have to be from your neurologist. It can be from whatever doctor is easiest to get the referral from, and that will get you set up for both voice and physical therapy, but make sure that you're asking for separate. And then to contact Rosi Physical Therapy, they've got a great website, and their phone number is 760-861-2624. I also put that in the chat for those of you that are following along in the chat. Again, it's 760-861-2624. As Brandon mentioned, we've known and worked with him for almost a decade now, and we're so excited that Jayme joined his staff. Speech therapy has been hot topic lately. So thanks everyone for joining us today. Do your exercises, and you can catch Brandon actually tomorrow morning at 10 a.m. for his movement, use it or lose it exercise class. We'll see you all then.